Okay, well, I think in the interest of time, maybe we can go ahead and get started. Um, Welcome everyone to our Neonatal NIRS Consortium webinar. Today's discussion is going to be a little bit different. We have a panel of NIRS experts and some interesting questions that if you filled out the survey, we can go over. We're just hoping to have this session be some interesting discussion about NIRS monitoring and where the field is going. Zach is going to share some slides and we will get the discussion going. If you have other questions, please just put them into the chat box and we can get to it. We're going to keep this pretty informal. But first of all, we wanted to thank you guys for being here today. I know a lot of people expressed they were hoping to watch the recording because it was a little bit of a challenge to make the meeting. And we wanted to especially thank some of our panelists that are here. Actually, we're hoping, do you folks maybe want to go around and introduce yourself? I'm going to just start with, on the top of my screen, we have Gabriel Altit.
Hi, I'm Gabriel. I'm one of the neonatologists at the Montreal Children's Hospital in Canada. Thanks, Val and Zach, for putting this together and inviting me.
Great. And then next we have Suma Hoffman.
Hi, everyone. I'm Suma Hoffman. I'm a neonatologist at Children's National Hospital in DC. And I'm really happy to be here. Thanks for inviting me.
Thanks, Suma. And then next we have Christopher Rhee.
Hi, everybody. This is Chris. I'm a neonatologist down at Texas Children's Hospital, and I'm also very excited to be a part of the panel today. Thank you.
Thanks, Chris. We might have a few more people joining in a little bit, but again, we're trying to keep things a little bit informal, so feel free to ask questions and or put questions and comments into the chat box. Okay, so again, I'm Valerie Chock from Stanford. I'm moderating along with Zach, if you want to introduce yourself.
Sure, yep, I'm Zach Vesoulis. I'm a neonatologist at Washington University and St. Louis Children's Hospital.
Okay, let's get started with some of these interesting questions.
All right, yes. So this is, the content today is based on the surveys that you guys were so nice to answer for us. And really the focus here is about where we are with NIRS in the NICU and where we think we need to be in the next 5 to 10 years. This is a similar slide to something I showed more than a year ago now, just sort of talking about where NIRS research is at this point. Interestingly, 2021, this is just based on a PubMed search looking at keywords for NIRS and neonates. There were more publications in 2021 than any year previously. And if you extrapolate the number of publications from 2022 so far, we're on pace to even exceed that. So I think we are in a growth phase right now. Many of the papers that are out there are sort of what we would consider the classics, covering a lot of the topics that we have a deep understanding of. Autoregulation, IVH, HIE, PDA, some review papers. But there are a couple interesting novel studies that I wanted to point out because I thought they were a lot different than what we've seen in the past. There was one paper that showed the feasibility of using a NIRS probe on a silo for a baby with gastroschisis that had their bowel out. I thought that was a very novel use. There's some interesting work on caffeine and renal oxygenation. So taking the focus a little bit away from the brain that we typically see with caffeine. And then there's been an increasing focus on an integration of NIRS with other technology, which is something that will actually come up in one of our later slides. So the first question that we asked is, what are you using right now clinically for NIRS monitoring in the NICU? And it's kind of split between a lot of different areas. This is one you could answer more than one question. So some of this is not necessarily exclusive use. The vast majority of folks were actually using NIRS for at least one clinical indication. So only 7% of you were not using NIRS clinically. HIE was the top use, followed by congenital heart disease being the second a most common one. But a question for first question for our panel here: are there any uses for NIRS clinically that you're doing right now that maybe don't fit in one of these categories, or does this pretty much cover all of your clinical use?
I mean, I don't know if you include CDH per se in the pulmonary hypertension category, but definitely there are some CDH infants that we actually choose to put the NIRS probe on, although it's like a kind of on demand by the clinical team. It's not protocolized yet in our NIRS protocol locally.
I'll chime in that, we use it standardly for the main 3 purposes that are listed there for ECMO, HIE, and congenital heart disease. I am working on a new protocol in our center to also expand its use to clinical scenarios like hypertension, concern for specific concerns like, not continuous monitoring, but if you have concern for a PDA, or you're monitoring a PDA, or if you are, concerned about neck, or, so thinking about some of those specific disease processes.
That's actually sort of related to another one of the questions here. So abdominal monitoring. So I guess that's one of the potential things. Are you're actually monitoring the abdomen itself, or is it the brain and the abdomen?
I think.
Sorry, go ahead. Yeah. No, and actually we also are monitoring, babies with hemodynamic instability, but with shock and sepsis. Mm-hmm. We'll also do this. Yeah.
Okay.
Well, Gabriel, sorry, I didn't get a chance to introduce you. Do you want to just introduce yourself to the group and where you're from?
Yes, I'm so sorry, I'm a bit late. So I'm Gabriel Variane. I'm a neonatologist here from Brazil. And I'm actually the medical director of our neuro NICU at Santa Casa, and have the opportunity to collaborate with Valerie in several studies, I think, about the NIRS usage on the NICU. So it's really, really nice to be here today.
Thanks for joining our panel. Also in the chat, Andy Hopper has said that he uses NIRS for feeding intolerance and neck diagnosis. I'm kind of curious, do people have like set protocols, or is it more like if you happen to be on service, then you're the one that says, oh, let's put the NIRS on this baby, or is it linked to, say, your neuro NICU or small baby unit, for example?
Locally, we have a protocol, so all the nurses have been trained. They have specific set criteria and populations for initiation, and then I guess to stop the NIRS monitoring. They have like training for the way to record it and chart it, and which values to actually alert the medical team, and what is the troubleshooting to do before that. But the team also has the choice to add on the monitoring for certain categories of patients if they feel that it fits. Because, for example, we have decided locally to not put the NIRS probe on babies less than 34 weeks yet, because we want to increase the kind of training of our nurses to avoid kind of injury of the skin and things like that before we implement it systematically. And we had cases where it's been requested by the medical team, and so it was implemented, and there has been on-spot training for these specific cases. But otherwise, we do have set populations that we monitor based on specific criteria.
In Houston, we have specific protocols, mainly around our congenital heart disease patients. That's probably been the longest standing protocols. More recently, within the past year, we are increasing our neuro monitoring of our ECMO patients to include NIRS as well as continuous EEG. And that's been probably just within the last 9 months or so, as well as working with a dedicated neurocritical care team.
For those of you that have clinical protocols that are in place, how are you actually using the NIRS monitor? Is this just sort of a broader part of your overall monitoring, or do you have actual thresholds and specific clinical guidance that should happen in response to the NIRS being too high or too low?
In the populations we use it on routinely, I would say it's part of the global monitoring. And honestly, I'm working to, revamp some specific guidelines, but I think without those, what you're mentioning, Zach, those specific guidelines, it becomes another piece of information that largely I feel like is just overlooked and not really assimilated into the overall clinical picture. Is my feeling where we are now at our unit, at least.
In our unit, what we've done, we formed a NIRS committee. So we have members from nurses, RTs, nurse practitioners, and MDs who are more interested, I guess, in the neuro NICU aspects, but they're part of the group. And what we do is every 6 months, we adjust the guidelines based on feedback from the local teams. And within these guidelines, there's a whole portion on when to alert and kind of what are the questions based on specific thresholds that we decided based on the literature we've reviewed and some of the expert consensus of people we've probed in the community. And so they tend to alert the medical team if the baby has been sustained below 50% of either cerebral or renal NIRS, because these are the two ones we monitor for the populations of CHD and HIE, or if there's been a drop from baseline of 20%. The other criteria for alerting is if the value is above 90% sustained. That's been kind of the cutoffs. But obviously, we also try to train the teams to recognize patterns rather than just absolute numbers, because we know that it's kind of a vital sign, right? You can have set values for bradycardia and tachycardia by age or whatever you use for low blood pressure or high blood pressure. But then there's a context, right? Like if a baby has been at 75 of systolic for 3 weeks and is suddenly at 55, maybe it's in the normals for the baby, but it's not normal for that baby. So we have to be careful too.
Yeah, we're doing just the same. So we use this as part of overall monitoring for the babies at high risk for brain injury. But similar from what Gabriel just said, we'll use this very, very likely not only looking at specific thresholds, but more looking as a trend monitoring and actual alert if have, for instance, an important decrease on cerebral sets, and always thinking about the physiology of oxygen delivery and consumption. So it's quite useful.
I think this is all really helpful, especially for people that are just starting out, rolling out their NIRS monitoring programs. Just as sort of a follow-up question, do you folks have any kind of ongoing education to keep the training up for the staff as well as, faculty at your sites? Because I think, with ongoing use, certainly people become more familiar with it. But for example, like at Stanford, we have a annual evaluation and quiz that providers have to take just to refresh their memory on a lot of these principles and the physiologic basis behind how do you approach abnormal NIRS values.
Yeah, so what we're doing here in São Paulo and for the centers that we're doing the NIRS monitoring, actually, we also have, Valerie, this annual like quiz that we try to train everybody. But what we truly, try to focus with the team is actually, having more people actually engaged and actually understanding what, is the importance of having this monitor at the bedside. And to do so every 3 months, actually, we brought a series of cases from that center, and say, oh, this is what we could see here. And in your baby, in your unit, this was why it was actually useful. So that's what we're trying to do here.
That's great.
Well, those are a great introduction or transition to the next slide, which is what are the biggest barriers to either implementing NIRS monitoring in general or expanding it in your NICU? And cost was a big one. That's, whether it was the probes or the monitors themselves, that was more than half the responses were about cost. But not surprisingly, another big chunk was the lack of RCT evidence. So, kind of going to the earlier discussion, how do you use this monitor in conjunction with the rest of your clinical guidelines, rather than it being just another number. Interestingly, very few folks mention training or education as one of the big barriers. That it must be easy enough or enough adoption that, or at least that's not their primary barrier. Then skin integrity, which we've also talked about too. So going a little bit more on the skin integrity piece of this, what sort of experience are you guys having with skin issues? Is that something that's common or uncommon? Is it generally mild, things like redness or bruising? Or are you actually having more severe adverse events?
So maybe I can answer that. At least for locally, we haven't had any adverse events regarding skin. We've been very cautious in the phases of integration in terms of the population we've been looking at and how we trained, I guess, the nursing staff, the NNPs, and then we had like champions. And each time we get new nursing staff, they get also as part of their, I guess, residency at the beginning for them, they get introduction to the monitor and how to install and how to monitor for it. Locally, we decided to do a check every care, but at least a minimum every 12 hours of the skin integrity. And they do remove the probe, they let the skin breathe a bit, and then they reinstall the probe after. And we did choose to not include right away our premature newborn population because of the concern of skin integrity, and wanted to make sure everyone on the unit was very accustomed to the technology and how it is used, and how to manipulate the probe and how to make sure that the skin is okay. I know that there are issues with pressure more than like burning issues. And so I know that we always put caution about how the probe is, making sure there's nothing pressing on it, like CPAP hats and things like this, to avoid having any kind of those pressure sores. But I'm sure that those that have more experience with more of the tiny babies, like the 22, 23, 24, are much more cautious in terms of pressure sores in these specific groups. So I'll let them kind of share their experience. I've heard that for some of these babies, we have to be very careful also about the glue that can melt under the humidity. So I know that some groups have introduced like the Mepitel behind, but I'll let other people speak on that.
Yeah, I'll chime in that I agree with the older kids. Their skin integrity is good. We see very little issues at all in the routine use, because right now routinely we use it in the full-term babies. But when I did my study on preemies, where I was having issues with some bruising that we, definitely was part of our consent process, is really on that perirenal monitoring, because in our protocol, especially for the first 72 hours, we keep babies in midline position for decreased IVH and don't do a lot of manipulating. And so if they're laying on that probe and we don't take it off, so for the preemies, we don't take it off routinely every shift, because that's a lot of stress on the skin. And so then the only issue wasn't a breakdown, it was just the bruising of the pressure of laying on that, because it's just we use the Invos neonatal sensor, and it's just like that slight thickness that we ran into issues with.
Yeah, this is Chris. I agree. I've only seen issues with bruising mainly on the flank probe positioning. However, for my research study looking at using cerebral NIRS, we did use Mepitel, and it actually allowed both the nurses to monitor the skin site more easily and transition the probe to different locations, and probably get a little longer lifetime out of a probe on a specific patient when we were monitoring for 72 to several days of life.
Yeah, I would say.
Did you see that the Mepitel helped with that glue melting as well? Because the only time I saw that glue melting issue that Gabriel was mentioning was on the flank as well.
Yes, we did. We have not had any issues with the probe itself, either kind of having that same effect on the Mepitel. So that was really only in a similar vein that I saw on the flank when the adhesive was directly on the skin.
Can I ask just a follow-up question on that? Locally, like, because I think cost of probes is obviously the main concern, right? So changing the probes all the time is obviously very costly for some of these, monitoring. And locally, what we've done, especially for the term babies, and obviously I'm not talking about the preemie population, which is on its own a specific group. We've been using the Mepitac to solidify, because we do remove it every 12 hours at least to make sure the skin integrity is okay. And obviously the glue starts becoming, less efficient, I guess. So we've been using Mepitac locally to kind of solidify very gently, and it's been working wonders. I don't know if anyone has experience with kind of, solidifying the position of the probe.
Yeah, we have several different studies that involve longitudinal monitoring, where we go back daily or weekly, and this is definitely not a FDA approved claim necessarily of how to handle the probes, but there's two ways. We've used both the Foresight monitor and the Invos monitor. Foresight makes a non-adhesive probe that's in a headband that can be very easily reused. The packaging says single use on it, so just to be clear that's definitely what the manufacturer recommends. But we found that they can be reused. It's actually the abdominal ones that last the least amount of time, because they get soiled very easily since they're down near the diaper, and that's the primary reason that they need to be thrown away. We also, in general, have converted all of our probes, even the Invos ones, to non-adhesive forms, so you can put Tegaderm over so if you either peel off the adhesive backing and put Tegaderm on it, or leave the adhesive backing on, you can hold it in place with things like the Billy bands for babies that are undergoing phototherapy. So it's not nearly as tight as like a CPAP hat, for example. It's much less pressure that's placed on the skin there. And using them non-invasively, then we don't worry about the glue either affecting skin integrity or melting or any of those sort of technical issues that people have encountered over time.
I think it was
this is
interesting.
Krista. I just want, or maybe, and again, Valerie, could please correct me. We've been using the NIRS, cerebral and renal in very low birth weight infants. I think going back about 10 years with very little problems using the Mepitel. But I think our nursing staff has gotten very used to avoiding putting things over the probe that put pressure, like the CPAP hats and like the Billy masks and things like that. So as the director of the neuro NICU, all the complaints about neuromonitoring come to me, and really there have been close to none. We did have the experience, actually, Valerie ran a NIRS study at a large number of network sites. And again, it was a new new intervention for many of them. And again, they did see, I think an occasional, especially at one site, saw some bruising in the very preterm infants. But again, it was, I think, because they were not avoiding, other devices being over the probe and putting pressure. And Valerie, if you want to sort of correct me.
Yeah. No, that's absolutely right. I think that's where the training is so important to the bedside nursing staff about the skincare and using the sensors. And I would also mention with the renal sensor, I can't remember who was saying, but like the baby lying on it for extended periods of time, yes, we have seen pressure injury from that. So, whatever protocol that your site follows for rotating the babies, even if it's like log rolling, so they're still midline, I think is still really important, so that we're not seeing the pressure injury in these micro preemies from just lying on the sensor. The other thing I would bring up is there was a study, I think the Safe Boost group published, about keeping the plastic or the paper on covering on the sensors, which seemed to have changed the validity of the measures by, I don't know, I want to say like 5% or something like that. So I think they were recommending not to keep the paper adhesive on the sensors. That I just remember coming across that recently.
Yeah, but I agree with Zach. You can put, even if you want to keep it adhesive, but you're worried, especially for the flank, that it becomes too adhesive. I started kind of somewhere down the line in my study putting strips of Tegaderm to decrease the adherence so that removing was easier, and that worked beautifully. And then I had a lot less issues with that.
Great. Sounds like Tegaderm or Mepitel is the way to go.
People are crafty.
Yeah, and I would say for the very tiny babies, we've monitored one 22-weeker and a number of 23-weekers. So it is possible, even in babies around 500 grams, to safely monitor them.
Absolutely.
But I agree with Valerie. It requires very strict attention to making sure everything is being done correctly. Just like everything for the that's true of every part of those babies' care.
Can I bring up one more point? Speaking of the tiny, tiny ones, is real estate. And it didn't come up here, but if you're talking about multi-site monitoring and you have umbilical lines and other, there's only so much real estate that you have. What are your thoughts on that?
Valerie has a nice photo of a baby with challenging real estate that I think that's in some articles, but yeah, I think it is possible to do this. But again, you have to be a little bit creative.
Yeah, completely. And Suma, how like there are people say, well, maybe you shouldn't put things midline because you want to do it on the left side or the right side, and you just can't do that with the micropreemie sometimes. There's just not enough room on the forehead or on the flank. And then the same thing, like, I don't know if some of you guys do abdominal NIRS monitoring, and we have to get really creative, especially with umbilical lines in place to try to find room for that sensor. So I'm curious how you guys navigate that too.
Yeah, I think that's where I was really trying, because we don't routinely use as much abdominal monitoring. And I didn't for my study. So that I feel like would be a biggest issue.
Yeah, we often we have abdominal monitoring as a part of our research protocols, and for the smallest babies, we often have to skip the abdominal monitoring for those first 3 or 4 days until they get a PICC line, and then it's not an issue at that point. But it is definitely a challenge.
If you can get the nurses to tape a little more creatively, I think it's very doable.
Yes. Yeah, it does depend on if you have somebody who's using the tape bridge approach where the lines are coming more vertically, that definitely gives you more space than the coiled approach on the side.
Yeah, we use the bridge, but I can foresee how on a 500-gram baby or 400-gram baby, you can run into challenge even with the bridge.
Yes.
But can I piggyback on this? I just want, because we work in phases of integration in my unit where, start with this phase, second phase, do a budget, do assessment of the impact and blah, blah, blah. And we're looking at maybe eventually integrating the whole premature population less than 29 weeks in the monitoring. And, one of the questions that came out is for the congenital heart defect, we decided locally that we would do the first week of life or until they go for intervention. For HIE, we said, well, until they're actually rewarmed and that they're stable 24 hours post-rewarming. And whenever we remove our amplitude integrated EEG, we remove the NIRS. But for the premature baby, I'm just when is your cutoff of saying okay, enough monitoring? Or is there any cutoff? Do they need to be monitored until they're 32 weeks corrected and on CPAP or room air? What is your kind of gist? Did you protocolize? Is it more variable? Is it based on the clinical team deciding, well, we're outside of the window of neck or of a significant ductus or, significant lung or shock because they were infected? When is your kind of routine timing of removing the NIRS monitoring? Because, the parents want to do kangaroo, and although it's not a contraindication, it's more real estate, like you mentioned, and manipulation becomes a bit more challenging. So I'm just wondering if you have a set timing.
And so routinely, actually, we monitor for the first week of life, and we're gonna monitor again, if we have any other kind of issue. But routinely during the first week of life, we're doing here in our center.
I would think, with studies like the Safe Boost studies out there being very focused on the first 3 days, if that's a area where there's a lot of RCT evidence, that would make that seems like the most logical step for people to do that. But I agree, monitoring for 7 days or 10 days, sort of that big IVH risk period, kind of overlapping with that zone, would make the most sense. Although we'll talk about it in some later slides, I think longitudinal monitoring, perhaps for other reasons than brain injury or hemorrhagic brain injury, we might expand it, or maybe do episodic rather than continuous monitoring that whole time. Speaking of RCTs, we actually talked mostly about skin safety and not RCTs, which is what I thought we were going to talk about, but that's okay. This is a little review slide of what's out there. And so it's not surprising that people cite a lack of RCT evidence as a barrier to implementation, because there are not very many studies out there. There's one from 2002 where they used it as a part of a transfusion algorithm, but they found that the provider comfort level with NIRS was so low that a lot of people were crossing over into the other arm of the study. So it actually wasn't very successful. This is 2002. This is quite a while ago. This is, I think, a very different era of NIRS. So it'd be interesting to see now with more familiarity if that would be different. And of course, the Safe Boost studies, which have been mentioned repeatedly now. There was a Safe Boost 2 study in 2015, and then we should have the results of the Safe Boost 3 coming up later this month. Anupitheria used at NIRS in an evaluation of cord milking versus delayed cord clamping, and found that there were no differences in cerebral saturations, but there was an increased risk of IVH. There was a head positioning trial. They actually randomized babies to 6 different positions for the head and looked at cerebral saturations and found overall that there weren't very big differences between the head positions, but head turning to the left or the right had slight decreases in cerebral saturation. And then Valerie has a paper coming out later this year. This is an updated paper with looking at thresholds and outcomes. So we're all very excited to see that later this year. So speaking of RCTs, especially Safe Boost, we asked for folks that don't necessarily use NIRS routinely in the preterm population, and if the Safe Boost study, if the phase 2 results are confirmed in a statistically powered group in phase 3, will you start using this in routine use? So nobody answered no, which I guess is good. That there were zero responses for that, and of course, about 20% are already doing it, and there was variable degrees of enthusiasm for the remainder. So for those of you on the panel that maybe are in the likely or possibly categories, what hesitation do you see? This is now something with RCT evidence. So what hesitations do you see for further adoption?
I can tell you, as I've already been working on expanding general use of NIRS and also incorporating training, et cetera, one of the issues that come up with is just our sheer number of monitors. Mm-hmm. And so if you expand the use to routinely do every single preemie for even 3 to 7 days, how many monitors do you need? What's the cost effectiveness of this, and how much benefit do you truly gain? So I would think that is probably that cost benefit, going back to that first question, is going to be what's there, because right now I think we have 6 monitors for a 72-bed unit, and so there's only so many monitors that we have. It's not like the routine monitoring.
Yeah, I completely agree. I think the next barrier that I would clearly hear, is okay, this seems to work. This is changing clinical practice. There will be lots of training. But what is the cost effectiveness? So how I can implement this to a large population? So I think this is the next barrier probably.
I 100% agree with both comments. We also have 6 monitors, and if we're monitoring all the HIE and all the CHD, and then suddenly we have to incorporate all our extreme preemie population, it becomes a lot of babies. And that's why I asked the timing, because like doing a 3-day monitoring versus a 7 days, well, your monitor is stick with the baby for 7 days, versus 3 days. Well, you're more likely to have an available monitor when it comes to the important timing. The other thing is, locally, when we look at our population, it's easier to sell to the team where is the problem in your population. So let's say, I'm going to give you an example, like locally, our babies born at 26, 27, 28 weeks are not the ones who die, and they're not the one who have severe IVH. So we get the occasional random one, which we're all surprised. Oh my God, there's like a big IVH, how come? And it's like a 27-weeker, but it's not the ones where we see that typically in our population. So, and we get much more 26 and 27-weeker than we get 22 and 23-weekers, right? So if you say we're going to start monitoring every single baby born at 27 or 28 weeks for the first week of life, people are going to say, well, that's a lot of babies, right? Versus if we say, well, our more concern comes into the 22, 23, 24, maybe 25. And these are the ones that have more IVH in our unit, let's say, or more risk of mortality. I think it's a better sale. Let's say, well, this is the most concerning population, even if I know that, you know, the safe boost will be including more mature babies and hopefully will show an effect and it will include these more mature babies. But I wonder if in an aspect of being cost effective and saying which population I want to improve the outcomes in, well, should we start integrating in that more kind of at-risk population before expanding and then do cycles of reevaluation, you know, every 6 months, a bit like in a QI process where you're introducing ways of altering your outcomes and you're seeing the impact. And if it does translate and change an impact, then, you know, you continue to invest and maybe you expend it. But that's where I you know, how I try to trade things out with my team, I guess.
Yeah, that was going to be my follow-up question. What, you know, if you're not adopting the full Safe Boost protocol or population, would it be gestational age restricted, or would it be some other severity of illness, like only intubated patients, or babies below a certain weight percentile, you know, less than 10th percentile for weight, or something like that?
I agree that, you know, trying to risk stratify your population and trying to see who we would argue needs the monitoring the most is probably can be both cost effective in the sense that you can target that population and not necessarily have to be so broad. But I think if it means for your unit that you have to, you know, monitor just for that first 72 hours, I think there would be certainly validity based on what evidence is out there. I think the only other thing that I was going to add that I think here we are only using it on a research basis in our premature population. I think having the results of Safe Boost 3 will help to move the pendulum a little bit more towards clinical care. But I think one of the other issues that I've heard amongst my colleagues is that, you know, obviously when you have a NIRS value out of range, you know, there are multiple interventions that you could use, whether that's, you know, the ventilator, vasoactive meds. We've talked about this before. And, you know, which is the right thing to do. Obviously, understanding the physiology is paramount, but I think that can be a challenge for a broad faculty group like we have down here.
Yeah, and that's I think all the more important because that's not one of the outcomes that's tracked in Safe Boost 3. There's a tracking of whether interventions were used, yes or no, but not which interventions, which ones were the most successful. There's really no, you know, it's really an examination of the entire package all at once, NIRS monitoring plus the entire protocol without risk stratification or examining those interventions.
And I wish they would track how many, and this is probably much harder to track, but how many things didn't get done because NIRS was in range?
Mm-hmm.
Like, did you hold off on pressors because the NIRS was in range? Did you not transfuse because the NIRS was in range? Because I think that's where you could probably avoid a lot of fluctuations, avoid fluid boluses, a lot of ups and downs if you are in a stable tissue steady state.
Mm-hmm.
Yeah, Suma, that's exactly what Zach and I have been talking about quite a bit, about like the cost effectiveness of actually, you know, not performing bedside interventions based on the NIRS. So very valuable. Yeah,
and each one of those things you mentioned, Suma, all carry risks of IVH early on. So if we can avoid them, that would be great. All right, so that was a lot of discussion about current RCTs. The next slide if it'll load for me. There we go. What should the next one be? Interestingly, a lot of people still mentioned IVH prevention or management, but I think a lot of that's really being covered in the Safe Boost study. I consolidated these groups a little bit. There were some free text answers, so I couldn't fit it all on one slide. There are definitely some folks that are interested in seeing studies about timing of surgery, potentially things like BP shunts or ventricular reservoirs as relates to IVH. But the top two choices were transfusion thresholds, which was number 1, and PDA management was number 2. So I guess let's maybe tackle the transfusion one first. Would you like to see a study that actually uses NIRS as a solo biomarker, for lack of a better word, for transfusion, or something in conjunction with hemoglobin? How do you envision the implementation of something like this?
Yeah, I think probably in conjunction with hemoglobin, that borderline babies, we are not sure if we should do the blood transfusion, yes or not, but I don't think alone would have enough.
I'll chime in here just because we had a recent, for our own division, trying to revamp our transfusion thresholds just based on the top trial results, for example. And we are actually incorporating NIRS as on top of a hemoglobin threshold. So like in the situation where, maybe you would meet threshold for transfusion, but your NIRS is okay, then to consider not transfusing, or vice versa. If, your hemoglobin is in appropriate range, but your NIRS is reading really low, and there are other, you've already maximized ventilator support, et cetera, then to maybe consider transfusion in that case. So I think we're using it, implementing it at least for a protocol as kind of like another marker to utilize to try to inform transfusion practices, and we'll be kind of studying that.
And Valerie, that's more specifically for cerebral NIRS, right?
For cerebral NIRS, correct.
Makes sense.
That's I guess kind of going back to the previous slide, that's another example of where NIRS could be used as a tiebreaker in both directions, to potentially do more interventions or fewer interventions. So it's I think that's one of the I don't know if biases is the right word, but I think there's definitely a perception amongst many neonatologists that using NIRS means more interventions for babies, but it doesn't necessarily, especially these well-designed intervention protocols can go either direction. It could be fewer interventions.
I think what people don't realize is we keep talking about these thresholds, but these thresholds are very low and the range is so wide. So to be out of threshold is quite significant. Like it's even on our cooling and ECMO kids or pre-ECMO kids, because once they're on, they should be stable, but you rarely see them so low, like less than 50. They're not sustained all the time. It's not super common. I think that's what people think, that these kids are going to be 45, 50 constantly, but that's really, in my experience, not the case.
And it might be shifting the perception of a NIRS monitor as sort of a super pulse oximeter, which I think is a common way that people think of it, to a device that's actually providing a very different kind of information than a pulse oximeter. That it's, this is not a baby that's setting 88. It's on a pulse oximeter. It's much more. This is more like a baby setting 60 on a pulse oximeter, sort of deviation. I'm moving on to PDA. What way do you envision this being used? As another piece of the puzzle about when to intervene potentially, or to track how PDA, whatever route you're taking, Tylenol, ibuprofen, et cetera, how effective it is at treating?
Maybe I can start on this. So I see actually a big benefit because locally, and I'm going to go back to, we have a very conservative management approach towards the ductus. And by conservative, it doesn't mean we do nothing. We actually do things to the babies when we think that there's a big ductus, but they're not necessarily giving NSAIDs or Tylenol. And sometimes I see things such as, preventing an extubation because people are worried that actually the PDA has effect, or, restricting way too much to fluids or giving direct. So I do see a benefit where NIRS could actually inform on tissue perfusion and maybe magnitude of the shunt, kind of a live assessment of the degree of steel, mostly when you're looking at your different, areas of monitoring. So I do feel like there could be a window using this technology if you do have a conservative management approach to more target these kinds of adjunct management strategies. So instead of preventing an extubation, if NIRS values are not concerning, maybe actually we should go on and extubate the patient. So things like that, where you could be a bit more precise in tailoring these kinds of, I guess, more biased types of intervention when it comes to managing the PDA, even if it's not in terms of deciding if you need to give endo or Tylenol or ibuprofen or whichever medication you're using. So I do see a place there. And when it comes to actually fine-tuning for those that do use interventions and medications to try to accelerate closure, I think that when you see that your renal NIRS are dropping in very low ranges, locally we've seen that, especially in the congenital heart defect population, those with big ductuses, and they start having this retrograde flow in the descending abdominal aorta and very large left to right shunts, and they overcirculate. We see very low renal NIRS in these patients. And so I think it will help guide to some degree, and hopefully there'll be a trial or there'll be an interventional study looking at, if this can better fine tune how we treat these patients. I know Valerie actually published a very nice paper on looking at that with the renal NIRS, and it might be a way to better fine tune, because echo will have limits. I hate to say that because I love echo, but it has its limits regarding that.
And then finally, for abdominal randomized trials, I guess some of you mentioned that you're actually using it as a part of your care now, either for research or as a part of your clinical care. Which questions would it be trying to identify babies who have neck through some sort of continuous monitoring? Would you use it to decide this baby's ready to advance their feeds, or maybe to fortify them? What sort of use case do you see?
Well, we haven't implemented abdominal monitoring, but I'm very curious to hear those that did implement, even in the context of research. And specifically, locally, we've been very concerned because we did a recent audit, and our cases are mostly isolated to the very growth restricted newborns and those with, absent or reverse and diastolic flow at the end of pregnancy. And so I'm just wondering, especially in that population, if there wouldn't be a benefit in trying to detect moments of intestinal ischemia or pre-intestinal ischemic events that might lead to eventual neck.
Suma, I think you mentioned you guys were doing some abdominal monitoring. Is that right?
Sorry, we aren't doing it yet in the NICU. In the CICU, they routinely monitor mesenteric saturations as part of their 2-site monitoring instead of perirenal. I think probably just because it's easier with most babies being supine for them. They do, I have paid attention to it as they're starting to feed the babies and noticing some quite low saturation numbers. My issue with mesenteric NIRS monitoring is that there's such large variation, especially with meconium passage, peristalsis, et cetera. So it's hard to know what to do with the numbers because they fluctuate so much.
Mm-hmm.
Yeah, I completely agree. We are not doing abdominal NIRS as well. And that's definitely the case about this huge variability on the numbers. It's a bit hard to understand. But I just wonder, and again, maybe, instead of trying to look into the absolute values and maybe even the trends, looking at the variability itself might bring us more information. But again, I think this is something that needs to be answered.
one thing I mentioned once to Valerie, and I think would be a really good or interesting study would be to actually look at the liver site, because the liver does not move. There's no peristaltism of the liver. And yes, liver will be impacted by the kind of metabolic activity it has, right? Like if you're giving a medication that will need some metabolism, you might think that there's more consumption of oxygen, but it is still perfused by the same arterial territory than your small intestine, like at least, the jejunum, the duodenum. So I wonder if there is some vasoconstricting effect that might, impair perfusion to some degree of the intestinal wall. Could there be some reflection on what's happening at the liver, which does not move, doesn't contract, but obviously it's not the same organ. So you could argue maybe the liver has an autoregulation capacity that's different than the intestine. But if I had a place to put a probe on the baby, I think I would put it in the right upper quadrant just because of this reason. Oh, Nimrod said that he published a paper looking at the liver.
Mm-hmm.
Wow, interesting.
Oh, what did you find, Nim?
Yeah, or Nim, do you want to put a link maybe to the paper in the chat? That would be great, so people can check it out.
No problem. I'm Nim Goldstrom, for those who don't know. I work at Columbia University, neonatologist and cardiac critical trained intensivist. I care for mostly CHD babies, term and preterm at Columbia University. So we use NIRS in our cardiac populations throughout the entire perioperative course, pre-op and post-op. They get 2-site NIRS pre-op, scalp, and renal. And then throughout the entire acute phase of the post-operative period, they have 2-site NIRS, renal, and cerebral. We do it until at least extubation, at least 24 hours after extubation. And then for high-risk kids who don't have great physiology, heart failure, dysfunction, CPAP needs that we can't explain, we continue renal NIRS, and renal NIRS are our go-to acute surrogate marker. And so to the groups that use abdominal NIRS in cardiac ICU, we specifically don't do that for the reasons you mentioned: too much variability, too much noise. It overcalls signals that aren't there. But renal is also a highly sensitive tool, but the variability isn't as crazy and just does help us be more thoughtful in managing hemodynamic support. The paper I did is in fellowship was to try to answer this question. There's so much noise at the abdominal NIRS, so I put one on the right upper lobe, right upper quadrant, excuse me, and another one on the left lower quadrant in 28 to 32 weekers for about 48 hours continuously, to try to modulate if there's still a response to feed, as other studies have suggested, that there's both NIRS response and mesenteric vascular changes with response to feed. And there was a signal. Again, it's weak, it's statistically significant, but it's far less variable. And you did see the same peaks that happen in postprandial effects of NIRS, where the peak was mostly highlighted around the 30-minute mark, and then kind of starts to baseline normalize around 60 minutes, and then just kind of flattens out after 60 minutes. I didn't have enough between bolus to continuous to kind of differentiate between those two, but the continuous feed maybe definitely had a blunted response as compared to bolus fed kids. So it was more stable. The baseline value was slightly higher, right? Because it's a much more mixed circulation at the liver than at the intestine, and the variability was less.
Great. Yeah, thank you for sharing. I know there are a couple of papers out of Italy where they've compared continuous to bolus feeds and found, as you would sort of expect, the continuous feeds have much more stable oxygenation without all that fluctuation. But I think that's part of the reason why there probably is not more of this literature in my view. I know of a number of people that are collecting research abdominal NIRS, including ourselves, and there are very few publications on it, I think, because we really don't know how to interpret it as such a more complex signal compared to the cerebral monitoring.
I wonder if you can look at it similar to what I think Gabriel is alluding to, is more that there'd be normal variability if the gut was working correctly. If you lose that variability, similar to the work on heart rate variability, would you see some predictive value there?
Mm-hmm. Yeah. Yeah,
To me, that's the abdominal signal right now. It's Variane. Like that's the only way I would use it clinically, personally, from like looking at these studies, is the loss and continuous variability. Right. Same can be said a little bit about the renal NIRS, although the variance is much lower. We do find that, especially in the cardiac population, like when you see just the mean value, start to deviate at least 25 to 30% from its previous baseline over like 6 to 8 hours, that's probably a clinical change, or that's an impending change. We've had, we need to publish this, but we had easily 3 to 4 in the last 4 years cases of kids who take this like precipitous change right in the first 12 to 16 hours post-bypass surgery, and the kind of like missed opportunity, right? Because then you're like near arrest physiology, and then they're, you look at their lactate and it's 7 all of a sudden, like somebody missed something there. And the NIRS like clearly was a very clean signal. It was not messy, and their baseline had dropped, 50% from where it was. And the heart failure kids are the same, right? When you walk by, he's on CPAP 7, 21%, and like mildly huffing and puffing on milrinone, and your NIRS are 30, your function is probably moderately severely depressed. And like, that's what you see, it supports the picture. It probably overcalls it sometimes in terms of like they're low, but the clinical picture looks better than the child, than the numbers suggest. But much more often in these cardiac patients, it is a good early warning marker of imperfect physiologies. And it has been extremely helpful in these neonates who are not progressing the way they should after surgery.
This is great. I think you're preaching to the choir, because we all have these experiences as well. I think it's wonderful. I think what makes it challenging is when people say, "Oh, should we hold feeds just because the abdominal NIRS or the renal NIRS is dropping?" And if how do you guys feel about that? Like, if the belly's not distended, if there's no other signs of feeding intolerance, I usually say, like, you can't just rely on that one value because of the variability, but you have to look at the whole baby, obviously.
Yeah, I don't know that we have enough information right now to know, that's another one of these things where it's the NIRS plus several other pieces of information. I don't know that we have the magic formula yet to answer that. And we're getting close to 1. So there's one more one more thing. This has been a great discussion so far. Thank you, everybody. What is the biggest improvement that could be made to NIRS monitors? So real-time cerebral autoregulation display was the top answer. And then improved integration with other vital signs, which thinking about the question later, I kind of wonder if those are actually sort of the same answer, at least in a sense. A lot of folks were interested in seeing improved probe designs, and then a little bit about improving sort of the user interface or how the device, how you interact with the device. So I guess thinking of integration, whether this is autoregulation or with other vital signs, what would you do? Is there something different you would do with that information than you would having a bunch of different screens or panels around the patient?
So right now, our CICU uses like a T3 system, ediometry system, and they have set algorithms that incorporate NIRS with the other vital signs as an early warning system. So something like that, if they're validated more, I think, for that cardiac population specifically, but if we have similar markers for our population in the, outside of cardiac, so, pulmonary hypertension or prematurity, pre-IVH, I think that would be those like early warning monitor systems is what we are looking for in like an ICU of the future.
Mm-hmm. Yeah, some sort of vital.
Yeah, and I would argue the same thing. I would have mentioned T3 as well. It's such a big cardiac program that their data is based off of. I know they're trying to enter in more NICUs, but I did my training in Boston, and they were developing out of there, so we ended up talking a lot with them. Their value is probably twofold. I think the visuals cannot be overlooked. The fact that they integrate the data and can overlay you all these data signals basically in near real time and give you a visual graphic, right, of data over time, right? So it's not like a Philips or GE monitor that you can second to second heart rate and beats, but you can look back like, hey, what just happened in the last hour? And you can get that view, right? And then you can see what signals are moving in what direction and kind of take a more comprehensive view of a baby. Like, hey, their baseline heart rate was all of a sudden 190. It was 160 an hour ago. And your NIRS are dropping, something's happened, right? Versus like, look at these stable vitals. The vitals have been like stable for 5 hours, but our NIRS are all over the place. Maybe it's messy. I think that integration of visually displaying to clinicians complicated data patterns in time and across time that you can zoom into 10 minutes, you can zoom out to 8 hours, right? And see patterns and kind of make more inferences. Is one signal off and that's the outlier, or multiple signals showing you some of the problem? And the second is because they kind of pipe in and get all this data, they're just ahead in the field. Again, I'm not trying to sell it. We do fine without it. I think it does have value, but the other thing is that you can easily interlace complex analytics, right? And so their big claim to fame now is this DO2 score, right? They're trying to interlace all these vital signs and lab data and try to predict when your DO2, your oxygen delivery or oxygen consumption is below 40, and what is the likelihood that your patient is an extremis. And that's great. I don't think it's a perfect tool for sure. It probably is highly sensitive and moderately specific at best. But their technology allows them to do that faster than anybody else, because all the data is time synced and linked, and they can run these research questions much faster.
Really quickly, Gabriel, Variane, do you want to talk a little bit about the PBSF approach? I think that it's very relevant to this question.
Yeah, so exactly. So what we're trying to do in the PBSF approach, actually, we're doing this multimodality monitoring, combining both EEG, NIRS, and the vital signs. And I think the beauty here is actually why NIRS is so useful is that because I think, both cerebral, renal, and even abdominal sets actually help us to better understand the physiology. But when we are combining everything, time synced, and doing this multimodal monitoring and helping the physician at the bedside to better understand the entire physiology might be quite useful. So we have actually a very nice experience using so combining the monitors, using a central hub at the bedside, and sending out the information to cloud servers, in which a team actually can, look at all these different vital signs, the NIRS monitoring, and the EEG as well, time synced. It's been quite a useful experience for us.
Yeah, I agree with Suma saying that that's the ICU of the future. That's I think that hopefully we all will get there someday. We have, like we've been talking about, we have too many patients and too many beds with too much going on. And if we have something that can identify problems in babies faster, then that should lead to better outcomes.
I think you almost need someone dedicated that's looking at these signals in real time on a subset of patients, because when you are rounding on 20 patients or plus, depending on your unit, it's hard to really take that time to look through the signals, go back in time, forward in time. You're not at the bedside all the time. So almost having someone manning the comm.
Yeah, like a epilepsy monitoring unit
exactly.
sort of structure.
Right.
Yeah, that's basically what we're trying to do also with PBSF. And of course, this brings a huge opportunity for all the AI tools and so on.
Mm-hmm. Down here at Texas Children's, we use SickBay, which is another platform that has similar capacity, that also has the ability to do background analysis of, complex waveform analysis. So I do agree. I think that that's the wave of the future. But how you harness that data is really going to be important as we move into those steps. And I think we still haven't completely figured that out. I think the other important point is that, that data, which is so nice, which Nimrod talked about, is, you can display that over 8 hours, 12 hours a day, a week. And our data comes up with, box and whisker plots, so you can see where those changes in physiology are happening across different variables, as well as integrating the ventilator data into that as well. So I think there's a lot of potential use for that, which is exciting, I think, for the future. It sounds like there's lots of places that are working on it. I know in the cardiac population, Ken Brady is also studying a auto-regulation type platform of multiple variables, probably similar to what was already spoken about, where they can use the combination of those to help inform the clinician at the bedside, which is obviously the biggest end goal for, I think, all of this research and work.
Mm-hmm. Yeah, absolutely. Yeah, and there are lots of different options out there. We've talked of some of them: T3, SickBay, Bedmaster is another one, ICM Plus. There are quite a few different things out there, many of which are commercially available, or custom fantastic projects like what PBSS have that's really custom made for their environment. So I guess just a few takeaways here. I prepared this in advance, so this actually may or may not match what we actually talked about. But I think it's pretty clear that this research is really accelerating, and we're sort of on the cusp of some very exciting stuff, especially integrating all of this together to get a really good picture of these babies. Major trial evidence is still a big missing piece. Also, how do we manage this? These probes, both from supply and logistics side of things, as well as skin safety and cost, especially in the VLBW population. And then we've asked some questions and we got some survey answers. If you have others, please send us emails about what kinds of programming you'd like to see in the future. Several different people mentioned that they would like to see recordings of these, and actually we have been posting all the recordings of our sessions since October 2020. We have 6 of them online. This one also is being recorded and will go up on YouTube at some point, hopefully later this week or early next week. And then also thank you to Gabriel. We have a website for the consortium group. And there's also links on there for the YouTube channel too, if you can't find it on YouTube itself. And that's about it.
Thanks everyone for staying a little bit over, and special thanks to our panel and all of you for this really enjoyable discussion. This was great.